This is Nazir Habib, and I would like to present application of non-invasive ventilation in the acutely hospitalized patient. My objectives are to review the types of respiratory failure, review the use of non-invasive ventilation, including indications and appropriate selection of patients, predictors of success, and avoid complications of non-invasive ventilation. Adults with respiratory failure often that are useful candidates for non-invasive ventilation include patients with COPD and acute respiratory failure, acute cardiogenic pulmonary edema, as well as other causes that I will review during this presentation. It is important to also consider individual characteristics of the patients, including their age, whether they have hypoxemic or hypercapnic respiratory failure. Most importantly, what is their mental status? If they have other comorbidities such as congestive heart failure, coronary artery disease, or obesity, as well as their code status. Let us take this first example of a patient with COPD who is 65 years old and that presents to the emergency room with dyspnea and has green sputum. His chest X-ray does not show any evidence of pneumonia. He is afebrile, he is tachycardic and tachypneic. His blood pressure is 80/50 and he appears clinically dehydrated. His chest examination revealed decreased breath sounds with distant wheezes, and he has signs of increased work of breathing. His initial blood gas in the emergency room show respiratory acidosis with a pH of 7.25, PCO2 of 58, and a PO2 of 58 on 2 liters oxygen. He has been initiated on antibiotics, bronchodilators, and low-dose steroids per the GOLD guidelines. So let us review acute respiratory failure. There are 2 types of respiratory failure. One is hypoxemic respiratory failure, as reflected by shunt or dead space ventilation with a PF ratio less than 250 or 300. Hypercapnic respiratory failure, on the other hand, reflects ineffective ventilation or neuromuscular fatigue, and one sees an elevated PCO2 above 45 or a pH of less than 7.35 in patients with normal blood gases at baseline. However, there are many patients who have acute on chronic respiratory failure that have chronic CO2 retention, in which case one would focus on the pH being less than 7.35 as a trigger for initiating non-invasive ventilation. These patients include COPD patients with chronic CO2 retention, as well as patients with obesity, hyperventilation, and various neuromuscular diseases. As we know, mechanical ventilation has many side effects and complications, and one would try to avoid mechanical ventilation if we had a candidate for non-invasive ventilation that could be successful. Complications of mechanical ventilation include ventilator-induced lung injury, nosocomial pneumonia, GI bleeding, muscle wasting, and myopathy, as well as delirium and post-traumatic stress disorder. The patient also are frequently uncomfortable and require sedation and occasional paralysis to synchronize their mechanical ventilation and avoid lung injury. Mortality is also quite significant, as is the cost and length of stay in the ICU. Therefore, selecting an appropriate patient for the use of non-invasive ventilation is important. As I mentioned, COPD exacerbation is a prime candidate for use of non-invasive ventilation, as well as patients with acute pulmonary edema or congestive heart failure, as long as they are not having an acute coronary syndrome. Immunocompromised patients also have a very high complication rate with mechanical ventilation and nosocomial pneumonia, and one would try to avoid intubating those patients as well. Patients who fail extubation, either with COPD or obesity hyperventilation, are frequently very good candidates for use of non-invasive ventilation. Other candidates include end-of-life patients, patients with mild pneumonia or ARDS. However, there are safety concerns with certain populations of patients, and one would like to avoid delays that could potentially increase their mortality. So let us review the selection criteria for the use of acute non-invasive ventilation. Respiratory acidosis, as I mentioned, is the number one indication. The pH is less than 7.35, associated with increased PCO2 greater than 45, associated with signs of respiratory distress, such as respiration rate over 25, worsening or moderate severe dyspnea, use of accessory muscles, and abdominal paradox as a sign of diaphragmatic muscle fatigue. The clinical examination is important to document, especially altered level of consciousness, increased work of breathing, respiration rate, presence or absence of paradoxical abdominal breathing, tachycardia. Also document baseline blood gas, as this will allow us to trend whether the patient is improving or worsening and may require mechanical ventilation. The contraindications to non-invasive ventilation are many. The primary one, obviously, is apnea or respiratory arrest or near apnea. The patient's altered mental status is a very significant examination that needs to be focused on, as the patient may not be able to protect their airway. Recent upper airway or gastrointestinal surgery, facial trauma are also important contraindications. If the patient is hemodynamically unstable, they're in septic shock, they have ARDS, they have cardiogenic shock, they have positive troponins and acute coronary syndrome, these are patients that should be intubated rather than managed on non-invasive ventilation, as they may develop complications. If a patient refuses or is uncooperative, it is very important not to proceed with non-invasive ventilation. Initially, the patient's NIV settings have to be determined with the help of the physician and the respiratory therapist. Appropriate mask selection is the job of respiratory therapists, and there are many types of masks available on the market. Mechanical ventilator settings should be discussed with the physician managing the patient. And most important, it is important that the patient's head of the bed is elevated, especially if they have obesity or upper airway obstruction, as the patient may develop further obstruction and decreased tidal volumes if the patient's head is laid flat. The initial BiPAP settings are important. The inspiratory pressure, or the IPAP, augments the tidal volume and lowers the carbon dioxide level. It reduces the respiration rate and work of breathing and improves muscle fatigue. CPAP, or PEEP, or EPAP recruits alveoli and stents the airway and therefore improves the oxygenation. This is particularly useful in patients with obesity, with atelectasis, or congestive heart failure. BiPAP includes use of both inspiratory pressure and expiratory pressure. In the initial settings, should be 8 centimeters, 4 centimeters, and then be titrated as the patient is more comfortable. The proper mask fitting and setting is very important. Patients do not tolerate a tight mask. The mask should essentially float on the patient's face, and the patient should have a leak of 70 to 25 liters as ideal, and the patient's machine can compensate leaks up to 60 liters. This is the ideal position of the mask, which should be parallel to the face. Any angulation of the mask will lead to leaks, especially into the eye, and the patient will not tolerate these leaks. In the first hour, it is essential that the respiratory therapist and the nurses and the physicians titrate the settings and monitor the patient closely. The patient's FiO2 is titrated to maintain an O2 sats between 90% and 94%. The goal of our non-invasive ventilation is to monitor to make sure that the patient's work of breathing is decreased and not increased. That will depend on the patient's tidal volume. One would like to deliver a tidal volume of at least 300 cc's, as 150 cc's is often dead space. Always check for the leak of the mask as it may be too loose or it may be too tight. Generally, sedation will help the patient accommodate non-invasive ventilation. I recommend avoiding benzodiazepines such as Ativan, which may lead to further obstruction of the upper airway. The best sedation is morphine 2 milligrams IV, which may be delivered every 15 or 20 minutes to accommodate the patient's non-invasive ventilation. If morphine is ineffective or the patient is still not able to tolerate non-invasive ventilation, I would recommend initiating dexmedetomidine drip at low dose. It is very important that the patients are kept NPO, at least for several hours, until we determine whether non-invasive ventilation is safe or if the patient requires intubation. The patient must be coached by the respiratory therapist and physician to ensure that the patient has the best fit of the mask and reassure the patients. Again, I would recommend pre-medicating the patient with a small dose of morphine, such as 2 milligrams IV, and observe and coach the patient for 10 to 20 minutes before the patient is comfortable. It is important that we do not restrain patients with non-invasive ventilation ever. So this patient with COPD is a prime example for success with COPD and non-invasive ventilation application. In summary, COPD patients with the use of non-invasive ventilation should have a success rate of 70 to 90% in avoiding endotracheal intubation, which results in significant decrease in the length of stay and mortality. Patients who are hypercapnic and have CO2 narcosis with decreased mental status may be treated with non-invasive ventilation, as their mental status will improve as the CO2 is lowered with the use of non-invasive ventilation. This has been discussed in this article in Chest in 2005. The mortality rate in patients with successful NIV is approximately 10%, as opposed to patients with COPD who are intubated that have mortality rate of around 25%. The baseline pH is an important predictor of success, and therefore I would emphasize that one obtain a baseline blood gases immediately prior to or after initiating non-invasive ventilation. This is a level 1 recommendation for the use of NIV in COPD. The second case that we often utilize non-invasive ventilation is in cardiogenic pulmonary edema, or CHF. Here's an example of a 65-year-old smoker who's a diabetic who arrives in the ER with non-invasive ventilation initiated in the field. The patient had sudden onset of dyspnea, although he denies any chest pain and he's alert. His EKG is normal, his troponin is normal, but his BNP is markedly elevated and his chest X-ray is consistent with congestive heart failure. He is tachypnic and he has increased work of breathing. His pH does not show respiratory acidosis as it is normal, although he is quite hypoxic. The study showed that in acute cardiogenic pulmonary edema, non-invasive ventilation induces a more rapid improvement in respiratory distress when it is combined with Lasix, morphine, and nitroglycerin. However, it has no effect on short-term mortality. If the patient does not have respiratory acidosis, one requires CPAP alone without IPAP. Another example of the use of non-invasive ventilation is community-acquired pneumonia and hypoxemic respiratory failure. This situation is much more challenging and difficult to manage. Here's an example of a 65-year-old male who's a diabetic, is admitted with fever and sepsis and bilateral pulmonary infiltrates consistent with pneumonia. His procalcitonin is elevated and his influenza is positive. His blood gases show a pH of 7.41 with PCO2 of 35. So he does not have hypercapnic respiratory failure, but he does have significant hypoxemic respiratory failure, as his PO2 is only 120 on 15 liters. His lactic acid is found to be 3.6, and when calculating his PF ratio, it appears to be less than 200, and this clinical picture is consistent with ARDS. In patients with ARDS or acute lung injury, it is important that we use caution in managing these patients with non-invasive ventilation. There have been small studies, and the data is really conflicting. However, in mild ARDS, if the PF ratio is less than above 200, one may try non-invasive ventilation. However, with PF ratio less than 200, one should consider intubation and mechanical ventilation immediately. If the patient is immunocompromised, one should discuss the code status and intubation status, as patients have a much higher complication rate on mechanical ventilation. And initially, non-invasive ventilation may be a good strategy. Other indications for non-invasive ventilation include obesity, hyperventilation, neuromuscular failure, neuromuscular disease, weaning patients and extubating patients from ventilator, and post-extubation stridor or ventilatory failure. At the end of life, one often finds conflicting discussions regarding patients managed with non-invasive ventilation. This recent study in 2018 in Critical Care Medicine reviews this issue. Over 2,200 patients that had DNI or comfort care orders, mostly with COPD and CHF, were treated with non-invasive ventilation. And over 60% survived hospital stay, and over 30% of these patients had a 1-year survival rate without any decrease in the quality of life or distressful symptoms. So one must discuss patient options, this data in mind, that non-invasive ventilation is also a very useful strategy at the end of life. Non-invasive ventilation at the end of life should meet its goals, and duration should be specified. Prime candidates for the use of non-invasive ventilation at the end of life include COPD patients, CHF patients with severe cardiomyopathy. Sometimes lung cancer patients may improve, as well as neuromuscular diseases. It is important to consider the complications of non-invasive ventilation, including aspiration pneumonia, atelectasis from dried up mucus plugs, as well as discomfort and agitation. And therefore, it is important to have ongoing discussions with the family and the patient, and do not withhold narcotics for comfort. The predictors of success for non-invasive ventilation are clearly earlier intervention when the pH is still above 7.25. Comprehensive staff training, including for respiratory therapist, is essential. One must monitor the blood gases and repeat the blood gases after an interval of 2 hours if the patient is remaining stable. Otherwise, obtain a blood gas earlier. One is looking for a respiration rate of less than 25 and a pulse rate of less than 110 as markers of success, as well as the patient showing signs of comfort and ventilator synchrony. Staff training and staff time is clearly increased with the use of non-invasive ventilation in the beginning. Respiratory therapists must titrate the settings, and the success rate depends on adequate knowledge and training. If the patient has altered mental status, their pH is less than 7.25, or if they have sepsis or pneumonia, we would generally recommend that the patient be admitted to intensive care unit. Otherwise, they may be safely admitted to a step-down unit. The safe use of non-invasive ventilation, one should consider the clinical course of the patient that we are predicting. If the patient has ongoing decline in a straight line in a patient that we're managing with non-invasive ventilation, it's most likely that we're just postponing the inevitable step of mechanical ventilation. An example of this is pneumonia and ARDS. On the other hand, if the patient has a good reversible process such as COPD, we are able to stabilize the patient and avoid mechanical intubation. NIV failure, signs or criteria include worsening encephalopathy, agitation, delirium, inability to clear their secretions or tenacious secretions, inability to accept any interface, hemodynamic instability or circulatory shock, such as patients with septic shock or ARDS. If the patient has acute coronary syndrome, cardiogenic shock, it is important to avoid non-invasive ventilation and proceed directly to intubation. And the patient may sometimes need to be transferred from the emergency room. It is important to secure the airway. Progressive respiratory acidosis and hypercapnia are clearly signs of failure. There may be several interventions that one may take to avoid air leaks, skin irritation, claustrophobia, nasal congestion, mucosal dryness, mucosal plugging, as well as risk of pneumothorax. By following these safe interventions that I have recommended, it is important to also humidify the patient's inspired air, especially if the patient remains on non-invasive ventilation over 24 hours. In summary, I would recommend non-invasive ventilation is most useful in COPD patients with acute exacerbation without pneumonia. There is level 1 evidence by many randomized controlled trials to support this use of NIV in COPD. The NIV is also useful in patients with cardiogenic pulmonary edema, as long as they're not having an acute coronary syndrome, asthma, community-acquired pneumonia, hypoxemia from atelectasis, and obesity hyperventilation. One must avoid non-invasive ventilation in acute myocardial infarction, circulatory shock, septic shock, altered mental status, excessive secretions, ARDS, and multiple organ failure. And generally consider intubating the patient if there is no response to NIV in a period of 1 to 2 hours, and ensure that the patient is kept NPO during this time. Thank you for your attention.